Okay, welcome to part 2 of cardiology. Here are the topics that we will be covering this week. We'll spend some time talking about shock, emphasizing hypovolemic shock. We'll talk about shock as it relates to cardiac arrhythmias. We'll go deeper into the atherosclerotic plaque by talking about peripheral arterial atherosclerosis, and then we'll talk about the contribution of lipids to the atherosclerotic plaque, and then briefly we'll talk a little bit about congenital heart disease and heart failure in infants. We spoke about this equation, cardiac output equals heart rate times stroke volume. Last week we covered contractile forces governing cardiac output. Last week we talked about hypertension as a resistance to the heart or the afterload. Today we're going to talk about how rate influences heart rate and how filling pressures influences cardiac output. Filling pressure meaning how much volume is in the tank, how much fluid we fill up the ventricle in order to generate stroke volume. My first day on as a resident in an ICU unit, I remember it well, it was July 2nd, 1987. As the attending physician was going home for the day, she says to me, "Ernie, all you got to remember is oxygen is good and blood goes round and round." Okay, I thought to myself, you sure you want to leave me by myself in this ICU unit overnight? And Dr. Day said, yeah, you can do this. So let's talk about oxygen is good and blood goes round and round. And as we move through this, you'll kind of see what I mean. Okay, a lot of different definitions of shock. When we talk about shock, what we want to be concerned of is circulatory failure. And remember, oxygen is good. Our cells need oxygen. And the way that oxygen gets around the body is through that equation, cardiac output equals heart rate times stroke volume. Circulatory failure would result in inadequate oxygenation of tissue. Or another way to think about it, cardiac output would not meet the demand for oxygen, and that would put us in a state of shock. Why do we need oxygen? We're not going to get into all that all over again, but remember, as we break down substrate for energy, the terminal step, if you will, in aerobic metabolism is the utilization of oxygen in the mitochondria to generate ATP. Our tissue always has a metabolic demand for oxygen, and that metabolic demand must be met by cardiac delivery of oxygen to tissue. When we're unable to meet that metabolic demand, we are then in a state of metabolic shock. So metabolic shock is cardiac output not supplying enough O2 for the oxygen demand. We have essentially 4 types of shock: hypovolemic shock, where we don't have enough filling pressure. So what we call that the preload. Not enough filling pressure means not enough volume in the tank. In those instances, we can measure a CVP, and we would find our central venous pressure would be low. Cardiogenic shock would be impairment of cardiac contractility. We would have low ejection fractions. We talked about that last week. Cardiac rhythm would be inefficiency of being able to generate adequate heart rate or adequate cardiac rhythm for our heart muscles. And then vasogenic shock would be a loss of the blood pressure. We also refer to that as afterload. That would be measured by a loss in systemic vascular resistance, where blood vessels just kind of like dilate, vasodilate up. And then we can have mixed forms of shock where we have where we can kind of mix this up and combine it. And that gets really confusing when we have a patient who's not kind of like in a pure form of shock, but more of a mixed form of shock. If you have taken the trauma life support course, or if you have taken the advanced life support course, or maybe you took the pediatric advanced life support course, they all define shock a little bit differently, but essentially what they're saying is if you don't have adequate cardiac output and you don't meet the metabolic demand of tissue for oxygen, you're in a state of shock. And this becomes life-threatening very quickly. Initially, shock can be reversible, or we can say the person has a compensated state of shock, but then after a while that becomes irreversible. That can rapidly lead to multiple organ failure and eventually become fatal. So we want to be able to recognize shock quickly and intervene on shock, and our interventions are going to be based on what type of shock we have found that person to be in. If we don't intervene on shock and tissue becomes ischemic, there could be numbers of consequences due to that. Cerebral, cardiac, renal, as well as connective tissue, any organ in the body that develops ischemia due to impaired cardiac output is going to have some grave circumstances. Ischemia to the brain leading to stroke, ischemia of the heart leading to angina, myocardial infarction, arrhythmias, and cardiac failure. We talked a lot about that last week. Ischemia of the kidneys leading to necrosis of the tubules, hemorrhage and edema in the kidneys. We're going to cover that next week. And ischemia of connective tissue due to peripheral arterial disease, and we're going to cover some of that as we move on here today. At a molecular level, what is it about ischemia that causes cells to die? Well, cells that don't get oxygen can become very quickly dysfunctional. Without oxygen, the cell doesn't generate adequate amounts of ATP. An enzyme which maintains the integrity of the cell membrane is called the sodium potassium ATPase enzyme. Without that enzyme, the cell membrane can break down, leading to cell edema and eventually necrosis. Without adequate O2, our cells shift from aerobic to anaerobic metabolism, and within the cell, lactic acid will accumulate. Without adequate oxygen, mitochondria will produce inadequate amounts of ATP to support cellular pathways. This can lead to inflammation within the cell by the release of arachidonic acid and release of intracellular calcium. So a number of intracellular mechanisms are occurring that eventually lead to cell death in the setting of ischemia. Hypovolemic shock is the most common form of shock. Hypovolemic shocks means we don't have enough volume in the tank. We refer to that as the preload. If we can't fill the ventricle with fluid, we won't be able to get adequate stroke volume out of the ventricle. And insufficiencies in stroke volume, therefore, can lead to impaired cardiac output. Hypovolemic shock may occur due to a loss of blood and red blood cells. Hypovolemic shock can result due to a lack of total body water. So whether we're losing blood externally or internally due to hemorrhage, whether we're losing water due to profound dehydration or profound GI disease such as cholera, vomiting, and diarrhea. Bottom picture is a picture of a refugee camp in Haiti where a number of individuals were suffering and dying from cholera after the 2010 earthquake in Haiti. So loss of blood or loss of water going to be our most common form of shock, hypovolemic shock. If we look at shock, let's look at how much blood and how much water we have in our body first. So a standard 70 kilo Healthy adult has about 5 to 5.5 liters of blood. In pediatrics, that's about 55 milliliters per kilogram. In terms of fluid, that 70 kilogram individual has about 40 liters of total fluid, so that's about 60 to 65% of total body weight is water. 2/3 of that's inside the cells. 1/3 of that is outside of the cells, so about 15 liters. And then of that component which is outside of the cells, about 3 liters of water is in blood. That's the plasma composition of blood. And about 12 liters of that water is in between the cells or in the interstitial space. And again, significant loss of blood or body water reduces preload. A loss of preload can lead to shock, and volume loss is the most common form of shock. As we start to lose preload for whatever reason, start to become dehydrated, start to lose blood, we will compensate by increasing our heart rate, and we will compensate through the renin-aldosterone system by releasing renin, beginning that renin-aldosterone cascade that will eventually lead to water conservation and vasoconstriction. So remember, we talked a little bit about that last week in terms of how that adversely affects congestive heart failure. But in actuality, in a state of volume depletion, that can be life-saving. How much blood can we lose? How much total body water can we lose? So we can quantitate that in terms of percents. I definitely want you to spend some time looking at this slide and look at what are the clinical signs and symptoms of blood loss depending on how much blood you lose, and dehydration depending on how much water you're losing. Once we get to 40% blood loss, that's lethal. No perfusion of vital organs. You can see that's somewhere between 2.5 to 3 liters of blood. Once we get to 20% dehydration, you can see that that's also lethal. No perfusion of organs begins to happen in an adult if they have lost over 6 liters of fluid. So be able to quantitate clinical symptoms to blood loss or dehydration based on the percent scales that I'm showing in this graph. What are the signs of hypovolemic shock? I would imagine that everybody here at some point has seen somebody in hypovolemic shock, either whether that was from hemorrhage or dehydration. And you can see that the symptoms between the two look extremely similar. Maybe the only difference between how a patient looks due to blood loss and fluid loss are the mucous membranes. Mucous membranes get extremely dry with profound dehydration, but with profound blood loss, while that can still happen, sometimes the mucous membranes don't dry out, but they get really, really pale. But take a look at this in terms of what's happening to heart rate, blood pressure, respiratory rate, capillary refill, neck vein distension, urine volume, urine density, skin color, mental status. So be able to pick out a case of an individual in hypovolemic shock based on the clinical presentation. Another thing that you can look for is the pulse pressure, the difference between the systolic and the diastolic. Like if a person's blood pressure is 120 over 80, the pulse pressure would be 40, 120 minus 80. And a person in hypovolemic shock, not only might you see the blood pressure falling, but you might see narrowing of the blood pressure as well. So for instance, you might see 80 over 60. So now the pulse pressure is 20, right? So now look at your systolic, your diastolic, and consider looking at the pulse pressure as well, as a narrowed pulse pressure can be indicative of hypovolemic shock. So here's two individuals, a 23-year-old who's been shot and a 44-year-old who collapses after completing a triathlon. Look at their clinical signs and symptoms, and you can see in each of these cases, it is a reduction of preload. So can you recognize the signs and symptoms symptoms of shock in each of these individuals. In case 1, can you estimate the blood loss? And in case 2, can you estimate the percent dehydration? Can you see the compensation in heart rate in each of these 2 individuals? And then remember, you don't see it, but simultaneously renin-angiotensin is kicking in, trying to get these individuals to conserve blood pressure, conserve sodium, and conserve water. What do we mean by compensated shock versus decompensated shock? An individual in compensated shock can have alteration in their vital signs, but they maintain perfusion. They maintain mental status, they maintain capillary refill time, therefore they're also maintaining some degree of organ perfusion. So in these 2 cases, is one or both of these patients in compensated or decompensated shock? How do we manage shock? I'm going to talk just really briefly about fluid. The first intervention for an individual in hypovolemic shock, whether it's due to blood loss or volume loss, is to replace isotonic fluid, often referred to as crystalloid. Fluid replacement in an individual in shock can begin as either lactated ringer solution, and you can see the components of lactated ringers, or it can begin with sodium chloride, normal saline, and you can see that normal saline is primarily sodium and chloride in water versus lactated ringers containing sodium chloride, but also having some other electrolytes in there as well. Rapid restoration of circulating blood volume is critical in those first minutes of managing an individual with shock. In an adult, we can start them with a rapid 1 to 2 liter bolus, or in a child, 20 to 40 cc's per kilo, given as rapidly as it can go in, typically over 15 minutes, depending on what type of IV access you have. Remember, the bigger the IV access, the bigger the line, the more rapid you're going to be able to get blood volume into the individual. So again, the key point is whether it's hypovolemia due to blood or fluid, the initial replacement is crystalloid, either in the form of lactated ringers or sodium chloride. There's some subtleties in terms of when an individual may choose LR versus normal saline, but I've always been taught and I've always resuscitated that if you're using sodium chloride, normal saline, you're not going to go wrong. There may be some instances where you don't want to use LR. I'm not going to get into that. So remember normal saline. Normal saline going to be just fine in almost every instance as you initiate your resuscitation of shock. What if the patient has hemorrhagic shock? Well, again, the first intervention is always the isotonic fluid, the crystalloid, and then that is followed with blood products. We're not going to get a whole lot into blood transfusion at all, but remember, most blood transfusions are limited to the packed red blood cells. If hemorrhage is extensive and ongoing, then whole blood, meaning the red blood cells and the plasma, can be given to the individual. But for a one-time transfusion where the individual is then stabilized, possibly all that needs to be given are the red blood cells and not whole blood. But in a big trauma resuscitation, there could be numbers of liters of whole blood which are given to that individual. So let's talk about rhythm and heart rate and how that can adversely affect cardiac output. So remember our equation, cardiac output is heart rate times stroke volume. So if we think about this just mathematically, a slow heart rate would drop cardiac output, and a fast heart rate could increase cardiac output, but too fast of a heart rate could also decrease cardiac output. And why is that? If the heart is beating so quickly that there's not enough time for the ventricles to fill, there's going to be inadequate stroke volume. So mathematically, if we looked at this equation just in terms of the math, a slow heart rate would always drop cardiac output. We know that that's not true. We know that a lot of people can have slow heart rates and have adequate cardiac output, but too low of a heart rate would definitely adversely affect it. And we know that as we increase our heart rate, such as when we're exercising, we can increase cardiac output, but then too fast of a heart rate where we can't fill the ventricles would also adversely affect cardiac output. So we have to be careful with the math when we look at this equation. Remember, the cardiac conduction system, the SA node is in charge. It controls the overall rate of the heart, so it's considered to be the pacemaker. Typical SA node firing between 60 to 100 beats per minute. SA node fires, sends its electrical activity through the atrium into the AV node. From the AV node, that electrical action potentials travel down the bundle of His through the septum to the apex of the heart, split into the left and the right bundle, and then travel from the apex up, sending the electrical activity up the myocardium such that the myocardium contracts from apex upward, contracting and forcing the blood out of the pulmonary artery on the right and the aorta on the left, and getting that blood into the lungs, into systemic circulation. If the SA node fails, remember that the AV node can take over, and if the AV node fails, we can also generate some cardiac rhythm through the bundles and within the myocardium itself. Normal sinus rhythm then is a sequence of PQRST, repetitive PQRST, P-wave atrial depolarization or contraction, QRS, ventricular depolarization or contraction, and then T-wave ventricular relaxation. And remember, we do not see atrial relaxation because there's just not enough electrical activity for that to be able to be seen in that rhythm strip. So you should know what is going on in terms of the cardiac conduction cycle, not only in terms of the three specific waves, but also in terms of the intervals. So if we say PR, beginning of P to R, if we say QT, beginning of Q to T. All that electrical activity, as we talked about in that first unit, is due to voltage-gated ion channels. And remember, we talked about a fast and a slow sodium channel. We talked about a potassium channel, and then we talked about an outward potassium efflux channel. And it's important to remember the ion channels because as we introduce arrhythmias and antiarrhythmic drugs here in a minute or two, all that effect is occurring due to ion channels. The action potential of the heart, there's 8 different action potentials in the heart, but there's really only 2 of them that we're talking about. We're talking about what does the action potential look like in the sinus node and what does the action potential look like in ventricular muscle. And to get this electrical activity, to get those action potentials to occur in the heart, that happens based on 4 different types of ion channels: a slow sodium channel, a fast sodium channel, a slow calcium channel, and an outward potassium channel. So the sodium and the calcium channels are moving the ions into the cell, and the potassium ion channel is moving the potassium ions out of the cell. As positive charged ions move into the cell becomes more positive, deflecting the electrical activity upward. As potassium ions leave the cell becomes more negative, deflecting the electrical activity downward. And if we were to just isolate the action potentials from the SA node and from the ventricular cells, we see that they look different. There's always a positive deflection up that we call depolarization, and there's always a negative deflection down that we call repolarization, RE, becoming more negative, repolarization. When you look at the SA node, there's 3 phases. They call them phase 4, 0, and 3. Phase 4 is due to a slow inward motion of sodium. Once it hits threshold, then the SA node fires by the calcium ion channel. And then for the SA node to relax and become refractory, that's the efflux of potassium. And then that cell can spontaneously fire again by that slow leak of inward sodium ions in phase 4. So notice how that baseline kind of slowly gets more and more positive. When it hits a threshold, it's able to fire again. That slow inward phase 4 is what gives the pacemaker cells what we refer to as spontaneous automaticity. The ventricular muscle looks a little bit different. Phase 4 is flat, and not until it gets a electrical conduction from the bundle of His or the bundles. Once that electrical conduction arrives, then it goes into a rapid phase 0 due to rapid sodium influx. And then we kind of see a hold or a plateau. And that plateau in the ventricle is due to calcium ions. That plateau is what allows the ventricle to relax. So it contracts and relaxes, contracts and relaxes. Take one of your hands right now and make a fist and hold it really tight. That's called muscular tetany, persistent rigid contraction. You don't want your heart to go into tetany. You want it to contract and relax. So open your hand, close your hand into a fist. Open, close, open, close. The reason that the ventricular muscle can relax is due to that calcium plateau. And then that's and then that's going to be followed by the potassium efflux in phase 3. And again, remember, that's repolarization. So there's a lot of ion stuff going on this slide. What I want you to remember, what's important to remember, is the slow phase 4 inward current of the pacemaker cells, which give it spontaneous automaticity, and that prolonged delay in the plateau phase in the ventricular cells, which prevents tetany. And then that heart's electrical activity can be captured and transduced from surface leads, and then that can be viewed on a monitor as the electrocardiogram. And we don't need to spend a whole lot of time talking about lead placement and running electrocardiograms, because I'm sure you've all do this on a daily basis and have all been trained in the 12-lead ECG and placing rhythm strips, right? We don't need to review that. And then the 12-lead ECG, we talked a little bit about this last unit in terms of using the 12-lead ECG depending on what lead you're looking at, determining what portion of the heart are you in. Are you in the right versus left side, the inferior right versus the lateral left, right? That's all based on where those leads are on your 12-lead ECG. And again, notice what you're seeing on the ECG does not look like what you're seeing in terms of the actual action potential, right? The action potential being generated at the cellular level is generating the electrical activity, and then the electrical activity being generated is what you are capturing on those surface leads, right? And then on those surface leads, you're looking at the cardiac rhythm. And in this case, you've got an individual who's in a normal sinus rhythm because you can see that repetitive PQRST. One interval that we should talk about here is the QT interval. And the interval means how long does it take to get from the beginning of the Q wave to the end of the T wave. And if you look at that graphic, you can see that I have the QT interval outlined for you. See how the red line starts at the onset of the Q wave and then ends at the end of the T wave. So that duration is referred to as the QT interval. As you should be able to recall, ECG paper is standardized. It's standardized into big and little boxes, where one big box contains 5 small boxes. The duration of time to move through a big box is 40 milliseconds, and the duration of time to move through a little box is 20 milliseconds. And you can measure that QT interval or any other interval by counting up the number of little boxes that it takes to get from beginning to end. So look at that QT interval, count the number of little boxes between Q and T, multiply by 40, and you get the duration of time in milliseconds. So again, I may have said it wrong, but let me correct it. The big boxes, 200 milliseconds. The little boxes, 40 milliseconds. 5 little boxes inside a big one, so 5 times 40 equals 200. Okay, that's the correct way. Big box, 200 milliseconds. Little box, 40 milliseconds. When calculating a QT interval, how many little boxes are in there between the onset of Q to the end of T? Count those little boxes, multiply it by 40, and then you get your QT interval in milliseconds. And what we're looking for is a QT interval greater than 500. If it takes too long, greater than 500 milliseconds, that can be problematic, as prolonged QT intervals can set an individual up for the potential of cardiac arrhythmias, particularly ventricular cardiac arrhythmias. Now we know in the real world, we use what's called the corrected QT interval, so the QTC, and that's dependent on heart rate. That's calculated for you in the 12-lead EKG. But I just want to go through this cursory QT interval exercise so you understand kind of how the corrected QT interval is being done. The corrected QT interval is based on the QT interval and the heart rate, okay? And the heart rate. That's what you get printed out for you on the 12-lead EKG. So here is a rhythm strip showing you 2 PQRST complexes. What I would like you to do is find the beginning of Q, find the end of T, count the middle boxes, multiply by 40, and then see if that is greater than 500. And when you go through that, you will see that this is a markedly prolonged QT interval, again, setting that individual up for ventricular arrhythmias. Those of you that are really good with EKGs could just look at this and not even calculate it and say, yeah, that is a really long QT interval, right? But calculate it out and see what number you come up with. All right, normal sinus rhythm, PQRST, PQRST. Remember when we are in the T and P wave, that is diastole, and we are in systole in QRS because QRS is ventricular contraction. Ventricle relaxes on the T wave and passively fills with blood. And then at the end of the T wave, the atria contract. Contraction of the atrium is shown in the P wave. That ventricular relaxation, the passive filling of blood, and then the atrial contraction. Now we've got a full ventricle, and now the ventricle can contract in the QRS. So we have diastole, systole, right, going continuously, but that contraction and relaxation of the ventricle in the atria is driven by the electrical activity, and that's what we see in the normal sinus rhythm. So now here is sinus bradycardia, and you can see sinus bradycardia is a sinus rhythm. It's just slower than 60 beats per minute. This is an effect of the parasympathetic nervous system. Remember, the parasympathetic nervous system slows down the heart rate. Now you should be able to think about different physiologic effects and different drugs that can slow heart rate down. Examples being rest, sleep, beta blockers, calcium channel blockers. So think of physiologic effects and think of drugs that can slow your heart rate down. And here is sinus tachycardia. So sinus rhythm just going more than 100 beats per minute. You can see that in the upper graphic there. And that is an effect of the sympathetic nervous system, specifically the beta 1 receptor. When the sympathetic nervous system fires, heart rate increases. And now think of different physiologic effects and different drugs that can increase heart rate. Fright, anxiety, pain, fever, dehydration, stimulant drugs, caffeine, nicotine, etc. A number of things can increase your heart rate and put you into a sinus tachycardia. Oh, so here we had, sorry, I had the slide in here. I said, go ahead and name some drugs and physiologic conditions which are causes of either sinus bradycardia or sinus tachycardia. I kind of said all that in the last couple of slides, but go ahead and rename all that because it's important for clinicians to understand why an individual may be in a sinus bradycardia or why an individual may be in a sinus tachycardia. Sorry about that. All right, then, if it's not a normal sinus rhythm, right, if you're not in a sinus rhythm, then you are in a arrhythmia, and some of these arrhythmias may be lethal. Some arrhythmias are lethal 100% of the time. Some arrhythmias have the potential to become lethal. So let's really quickly review some of these arrhythmias. And again, we're not going through a whole ACLS course here, but it is important in a pathophys course to talk about cardiac arrhythmias. So we'll highlight some of the more important ones. First off, why do arrhythmias occur? The most common cause of cardiac arrhythmias is myocardial ischemia, again, due to acute coronary disease. That could be acute ischemia, where demand suddenly does not meet supply, or it could be long-term effects of chronic ischemia, where tissue is becoming slowly infarcted or slowly dysfunctional due to a lack of oxygen. But as you can see, numbers and numbers of different things can lead to cardiac arrhythmias, from malformations of cardiac anatomy, from inflammation of cardiac anatomy, as you might see from autoimmune diseases, infection of heart muscles, scarring of heart muscles and scarring of valves, other causes such as electrolyte and pH abnormalities, drug-induced, electricity, hypothermia, right? So when you see an individual with an arrhythmia, you want to identify that arrhythmia and immediately intervene on the hemodynamic portions of that arrhythmia. But then you also want to consider, why is that arrhythmia occurring? What might be the underlying cause of that cardiac arrhythmia? So this is another important slide for you to review again. What are all those varying things that can cause cardiac arrhythmias in the first place? So ischemia and all those other secondary causes can lead to cardiac arrhythmias, and what happens is you get alterations of the action potential. The action potential can be blocked, which can lead to varying types of heart blocks. And action potential may come on too early or in an aberrant fashion. This can lead to things like premature atrial contractions or premature ventricular contractions. The action potential can find itself caught up in what's referred to as a re-entry loop, where electrical activity is just continuously generated in a loop circuit. That loop can involve the AV node, where that most commonly leads to supraventricular tachycardia, or that loop may only involve the ventricle itself and not be part of the AV node, leading to ventricular tachycardia. Or you can just get the sudden, random, chaotic firing of action potentials if that occurs in the atria, placing the individual in atrial fibrillation if that occurs in the ventricles, ventricular fibrillation. So we'll look at these a little bit closer as well. Here's an example of blocking action potentials. What's wrong with this strip here? You can see P waves, you can see some type of prolonged QRS, but you see that there's no association between the P and the QRS, right? Unlike normal sinus rhythm where each P wave is associated to our QRS, so you get a P and then you get a conducting QRS right after. Here you see no association between the two. You're failing to propagate the action potential from the AV node, from the SA node through the AV node. This is referred to as a third-degree heart block. P waves do not conduct into the bundle of His and the ventricles because we have completely blocked conduction in the AV node. And that manifests on the surface electrocardiogram by a complete dissociation of P waves and QRS. Again, some patients may be able to tolerate this for a short period of time, and in other individuals, this can rapidly become lethal. One thing that may need to be done to the patient who goes into a third-degree heart block may be the need for emergent cardiac pacing, whether that's pacing transdermal with patches on the skin or a pacemaker immediately put in quickly transvenous in a cath lab. There may need to be some type of electrical activity delivered at or below the AV node to get the ventricles to fire in a faster rate. Because in this case here, cardiac output is dropping because the heart rate is too slow, right? People in AV, full AV block or third-degree heart block, very often cannot get heart rates over 50, right? And sometimes it's even lower than 30 in some of these individuals. Here's an example of an action potential firing too early. So we see nice PQRST moving through this whole rhythm strip, and then suddenly you get this PVC, you get this premature ventricular complex. Now we all at some point have PVCs. May not be uncommon to have a couple of 1 or 2 PVCs in some individuals every minute. Sometimes PVCs are not problematic. The individual who's having multiple PVCs, and particularly PVCs with different morphologies, that might be problematic and that might lead to cardiac arrhythmia. Again, just like in an arrhythmia, you see an individual having multiple PVCs and multiple morphologies of the PVCs. Look for underlying causes such as electrolyte abnormalities. And in some individuals, they may need to be placed on an antiarrhythmic drug to suppress the firing of those PVCs. Let's look at examples of re-entry arrhythmias. So again, in the normal cardiac conduction, we go SA to AV through the bundle of His, through the Purkinje fibers on the left and the right, up into the myocardium, and then that action potentials terminate out. It doesn't perpetuate. Some individuals will have a additional aberrant tract, if you will, conductile tissue, and now conduction can move through the atrium and the ventricles in a loop or in a circuit. And very often that circuit, if it's moving through the atria and the ventricles, that circuit then can involve the AV node. And this is what sets up supraventricular tachycardia, a very fast, narrow, regular, even-paced tachycardia. In kids, I've seen SVT go as high as 230 to 240. In adults, you can certainly see SVT hit rates of 180 to 200. And again, usually due to some type of aberrant pathway that allows the action potential to continue as opposed to end. The action potential can continue through an aberrant pathway, and then that aberrant conduction can set up very rapidly in a loop leading to SVT. Here is a re-entry arrhythmia that occurs in the ventricle only, and you can see in this animated graphic, you can kind of see like a spinning loop. Notice that that loop does not get up into the atrium and doesn't involve the AV node. So fast loops within the ventricle can lead to ventricular tachycardia. A fast, evenly paced tachycardia, but the QRS interval is typically widened out. And that may, emphasize may, be one way that you can differentiate SVT from VTAC is by the duration of the QRS interval. For this course and for this course only, I'm going to make it easy, and that if I tell you that it's a narrow, regularly paced tachycardia, we'll make the assumption that it's SVT. If I tell you that it's a wide, regularly paced tachycardia, we'll make the assumption that it's VTAC. But for those of you that have a lot more cardiac skills and have been doing this for a while, you know that we can have SVT that also looks wide complex as well due to aberrant conductions. We're not going to get that detailed in this course. What I do want you to understand the difference between SVT and VTAC in terms of the loop, and at least for this course, let's make the assumption that narrow complex will be SVT and wide complex will be VTAC, okay? Why do these re-entry arrhythmias lead to drops in cardiac output? It's all about how fast you're going. Whether you're in sinus tach or whether you're in VTAC, if you're going too fast, you don't spend enough time in diastole, you don't have enough time filling the ventricle, and if you can't fill the ventricle, you can't eject blood out, you can't eject out adequate stroke volume, so those really, really fast heart rates can in fact compromise cardiac output. Sometimes people can tolerate these for a short period of time, and sometimes they are immediately lethal. So in a person in SVT or VTAC, you're going to have to do that hemodynamic assessment really, really quickly and determine, are they compensated or decompensated? People tend to tolerate SVT better than VTAC, and that holds true in children as well. Infants and children tend to tolerate SVT much better than VTAC. So we're going to talk about how can you intervene on some of these arrhythmias. In terms of SVT, you can slow it down by using a drug that works in the AV node. You can't do that with VTAC because VTAC usually doesn't involve the AV node. In each, you can use a drug that can convert you back to normal sinus rhythm, and in each, you can use electricity, electrical shock, which can convert you back to normal sinus rhythm, hopefully convert you back to normal sinus rhythm. So here's another slide that's important, be able to understand differences between SVT and VTAC. Here's an example of a chaotic random arrhythmia, and I like to consider this the popcorn arrhythmia. Why do I call it that? So take a pan, put some butter in it, heat it up, get it nice and hot, and then take a handful of popcorn seeds and throw those popcorn seeds on the pan, and all those popcorn seeds will fire all at the same time, right? They'll pop all at the same time, right? No, that doesn't happen. You get random popping of those seeds, right? Well, ventricular fibrillation is random discharge of action potentials. And when you get this random discharge of action potentials, you can't get coordinated conduction. And when there's no coordinated conduction in the ventricle, you can't get coordinated contraction. And when there's no coordinated contraction, you get no cardiac output. So ventricular fibrillation is just a bunch of chaotic random action potentials that leads to inefficient conduction. And then when there's no conduction, there's no contraction of the ventricles, therefore no cardiac output. So in individuals in VFib, as I have down in the lower right, there's no cardiac output in VFib. There's electrical activity, but it's bad electrical activity. It's electrical activity which is unable to generate any effective contraction of the ventricles. Always lethal. And then atrial fibrillation, now the graphic is a little bit off here. The graphic here that I found is kind of like showing you a loop in the atrium. That may be more indicative of something called atrial flutter. But atrial fibrillation, think of random chaotic electrical activity showing up in the atrium, and then some of that electrical activity will hit the AV node and conduct through the AV node down His into the bundles, and then you can get a nice ventricular contraction. So if you look at AFib, the aberrant chaotic electrical activity is on the baseline where you expect the P wave to be, and then some of that electrical activity can get through the AV node, conduct down His into the ventricles, and then get a nice ventricular response. Sometimes the ventricular response in AFib is relatively controlled. Sometimes the ventricular response in AFib is really fast. Almost always, though, the ventricular response is irregular. So rather than getting a nice paced rhythm, you get an irregular rhythm, which might be very fast or kind of mild to moderately fast. Individuals can tolerate atrial fibrillation. Some individuals can tolerate atrial fibrillation for a prolonged period of times, and a lot of that is depending on how quick is the ventricular response. In this case now, the ventricles can contract properly, but the atria are not. And by inefficient contraction of the atria, that can lead to stagnation of blood in the atrium. So a lot of you know that individuals who are in chronic AFib will be on some type of anticoagulant medication to prevent clotting in the atrium and therefore prevent emboli coming out of either the pulmonary side or the aortic side. And we covered some of those anticoagulants in a previous chapter. Okay, here is a lethal arrhythmia. It's called torsades de pointe, twisting of points. And this usually develops in individuals with QT prolongation, and particularly if a PVC fires, and the PVC fires in a critical timing of the QT interval. Look at this in a second here. A lot of drugs were pulled from the US market due to QT prolongation. People get on a drug, QT interval prolonged, developed a PVC or PVCs on top of QT prolongation, and they went into this twisting of the points or torsades de pointe cardiac rhythm. Not quite VFib, but again, very chaotic in terms of the electrical activity. Torsades de pointe, even though it looks a little bit more organized than VFib, you still are not getting cardiac output in an individual in torsades de pointe. So this can be lethal very, very rapidly. Any new drug coming onto the US market must be tested for QT prolongation. And if a new drug coming onto the market is showing QT prolongation in preclinical studies, that drug has a very poor chance of being approved and getting onto the market. So I made a big deal about QT prolongation, and in the real world, QTC prolongation. And the reason for that is that increases the individual's risk of torsades de pointes. Here's an example of 5 drugs that were on the U.S. market, all of which were pulled due to individuals who died due to QT prolongation and torsades. For those of you who have been in medicine for a while, you probably remember Seldane and you probably remember Propulsid. Those were 2 drugs that were very commonly used. Seldane as an antihistamine, Propulsid as a drug to manage gastroesophageal reflux disease in both adults and infants and children. They were good drugs therapeutically. They did what they were supposed to do, but their adverse effect was QT prolongation. Individuals died of torsades de pointes, and those drugs are pulled from the market. There are still drugs on the U.S. market that have QT prolongation warnings, and you know that because you've seen these drugs: antipsychotics, antidepressants, non-morphine opiates, specifically drugs like meperidine and methadone, fluoroquinolone antibiotics, ciprofloxacin, moxifloxacin, macrolide antibiotics, specifically azithromycin. A lot of you are probably aware of the new warnings that have been put out by the FDA regarding QT interval prolongation due to azithromycin, and some antiemetic drugs as well. Some of our antiemetic drugs may also have QTc prolongation warnings on it. So what does that mean? These drugs are still in use. They're good drugs. They're therapeutic. They do what they're supposed to do therapeutically, but you got to be careful. You may want to be looking at EKGs before the individual started on the drug, looking to see if they already have some cardiac conduction deficits. You may want to follow EKGs as they are on the drug. And you want to be careful about those warnings. If you're putting drugs into your electronic system like Epic or whatever you're using, and the person's on polypharmacy, and it's picked up that you've now got an individual who may be on 2 or more drugs which have QT prolongation interval warnings, you want to be cognizant of that. And you want to consider, hey, if all of a sudden I got a patient on 2 or more drugs prolonging the QT interval, I may want to seriously think about changing or stopping some of those drugs to lower that risk. So be cognizant of polypharmacy. Polypharmacy, drugs being prescribed from multiple different providers, that can be problematic. You know, if the left hand doesn't know what the right hand is doing, and you're setting an individual up for increasing risk of adverse effects, one prescriber may not see that. So pay attention to some of those warnings. I know some of those warnings, like in Epic, you know, sometimes they're treated like noise, but this is a big one. QT interval prolongation due to polypharmacy can be problematic. And then this rhythm, people know, no electrical activity, that's asystole. Again, if you got the leads on wrong and the leads, you know, pull apart or whatever, you're going to see flat, so everybody knows that, right? You see asystole on the monitor, check those leads, be sure they're all connected, right? But in asystole, true asystole, no cardiac output because there's no electrical activity. So if there's no electrical activity, there's no conduction, therefore there's no contraction. No contraction means no cardiac output. Okay, now a cardiac arrest. So an individual has no cardiac output. And let's assume now that might be due to an arrhythmia. For whatever reason, now this individual has no cardiac output. You need to support that cardiac output, right? So we're not going to talk about running a code, but you understand someone with no cardiac output needs CPR, airway breathing, cardiac monitor. They may need counter shocking. But let's talk about epinephrine. Epinephrine in cardiac arrest. It doesn't matter why the individual's in the cardiac arrest. It doesn't matter really what the arrhythmia might be causing the cardiac arrest. If they're in a cardiac arrest, we need epinephrine. And epinephrine has 3 activities at the alpha-1 receptor. It's going to cause vasoconstriction, increase blood pressure, at the beta 1 receptor, help to increase conduction, help to increase ventricular contraction, and at the beta 2 receptor, give us some vasodilation, and particularly in the coronary arteries, provide some increased blood flow through the coronary arteries. So epinephrine, right, every 3 to 5 minutes in the cardiac arrest. In terms of sudden cardiac arrest, particularly outside of the hospital, the most common form of sudden cardiac arrest in adults is ventricular fibrillation. And then in ventricular fibrillation, we also want to be sure that we provide electrical activity in terms of defibrillating that individual. So here is the Zoll AED, automatic external defibrillator. I know you've all been trained on this. You all know how to use it. The automated external defibrillator is going to send somewhere between 200 and 400 joules of electricity through the individual's chest, through the heart, and the idea is to send that electrical activity through the heart and cancel out all the aberrant action potentials. When all that electrical activity is canceled out, the hope then is one of the pacemaker cells will pick up and regenerate a perfusing rhythm. So I have a Blackboard thread where you can chime in and tell us whether or not you were ever at an event where you used an AED in the field. Again, the reason that we're trying to train individuals on AED, lay people on AEDs, and have these all over the place, at sporting venues and public buildings, etc., is because of that out-of-hospital cardiac arrest, and the most common cause of out-of-hospital cardiac arrest in adults is ventricular fibrillation. Part of that resuscitation is going to be recognizing it and counter-shocking them out of it. So again, if you use this AED, you know that the AED can recognize VFib, and then rather than it spontaneously sending a shock, it tells you as the rescuer the shock is indicated. You need to clear people off the patient, and then you can press the button, and then the AED will deliver the shock, right? So it doesn't do it spontaneously. It recognizes the rhythm, and then it tells you, the rescuer, to do it. Now a little bit of fun. Let's talk about the antiarrhythmic drugs and where they work. Again, really briefly, just to show you the importance of ion channels and how that works with the drugs. Antiarrhythmic drugs can be put into one of 4 classes, class 1, 2, 3, and 4. Class 1s can be further subdivided into A, B, and C. And then we have 2 antiarrhythmic drugs that don't really fit into any of these classes really nicely. We have adenosine and we have atropine. You can see that class 1s primarily work on sodium channels. Class 2 are beta 1 blockers. Class 3s work on that outward potassium channel. And our class 4s are calcium channel blockers. Any drug that blocks potassium efflux or blocks that outward potassium channel has the risk of prolonging the QT interval. And you know now that prolonged QT interval can be problematic, setting an individual up for torsades. So some of these antiarrhythmic drugs, while they can manage and counter arrhythmias, they may also induce arrhythmias. And for those of you that work in cardiac care, emergency medicine, you know that you've got to have a high level of respect for these drugs, because if you choose the wrong one, and sometimes even if you choose the right one, you can actually generate an arrhythmia versus manage an arrhythmia. So that outward potassium efflux channel, I never mention it. It's called a HERG channel, H-E-R-G. So again, all new drugs going into the market, going into the US market, are tested for their ability to block the HERG channel. And drugs that block the hERG channel, that block potassium efflux, have the risk of QT prolongation. Some of those drugs are still on the market. The new drugs that they're trying to get to market, if they are shown to be hERG channel antagonists, they may have a hard time and they may not be approved for release, again, due to that risk of cardiac arrhythmia. Class 1 and Class 3 drugs. So Class 1 drugs inhibit sodium ion channel depolarization. Classic drug there would be procanamide. Class 3 drugs inhibit potassium channel repolarization. That's the hERG ion channel. Drug there, example of a drug would be ibutylide. These are good drugs for blocking re-entry loop arrhythmias, so things like SVT, VTAC, PVCs, VFib, and AFib, even though VFib and AFib are not re-entries, those are random generation of action potentials. Both Class 1 and Class 3 drugs may be indicated for those arrhythmias. And again, you would want to go through an ACLS course and go through the algorithms in a real life scenario to determine which would be the most recommended drug for the specific scenario that you are in. Here I'm just kind of reviewing for you the mechanism of action. And then Class 2 and Class 4 drugs are the ones that are going to slow heart rate. Beta blockers are Class 2. Example would be metoprolol. Calcium channel blockers, the Class 4 example would be verapamil. What these drugs are doing is they're blocking conduction in the AV node, so they are capable of slowing down heart rate. So fast arrhythmias, which involve the AV node, such as SVT and AFib, Class 2 and 4 anti-arrhythmic drugs may be indicated to slow down the heart rate if that rate is too fast and the person is hemodynamically showing signs of hemodynamic instability or risk of hemodynamic instability. You can slow that heart rate down, get a slower, more effective ventricular response by the beta blocker or the calcium channel blocker inhibiting conduction in the AV node. Can you use Class 2 and Class 4 antiarrhythmics to slow down VTAC? The answer is no, you're right. And why? Because in VTAC, the AV node is not involved. So if your drug works in the AV node, it ain't going to be effective for that type of arrhythmia. Adenosine is in its unique class. Adenosine is a drug that can have a temporary but complete block, completely inhibit conduction through the AV node. It does that at a receptor called the adenosine 1 receptor. And when it does that, it inhibits ion movement temporarily through calcium-potassium ion channels. So its effect is to temporarily stop all conduction in the AV node, and this is beneficial for terminating SVT, right? And only lasts for a couple of seconds. You see this very transient moment of asystole once you give adenosine, and then ideally, once you've put that block on and that block wears off, SA node may pick up again and get that individual back into a slower, more beneficial sinus rhythm. This is referred to as chemical cardioversion versus when you apply electricity and shock someone out of an arrhythmia, that would be electrical cardioversion. And you know adenosine only has a couple of seconds of action. That adenosine drug is very rapidly taken up into the red blood cells, and when it gets inside a red blood cell, it has no effect. So you got to push that drug fairly rapidly with a flush to be able to get that drug to the heart and allow it to have its effect. So will adenosine have any effect on VTAC? And the answer in that case is no, right, because VTAC not involving the AV node. Adenosine is a wonderful drug. For those of you who have seen it and used it in SVT and got a patient out of SVT, it's very, very cool how quickly that works, right? There's some good YouTube videos that you can look up where people are using adenosine, the cardiovert SVT. Maybe there's a nice video. I'll send that out in an email for you guys to take a look at. Okay, we are done with arrhythmias. We did a really cursory of arrhythmias. I know that, you know that, particularly if you've got a lot of experience in cardiology, but I think it was just enough to introduce that topic for the short period of time that we have. You really want to do an ACLS course to get deeper into recognizing the arrhythmias, assessing hemodynamics, and then coming up with those algorithms, step-by-step plans to intervene on the arrhythmia. So that's a little bit of foundational stuff for you. Okay, now we want to move now we want to move into another topic, and we want to talk about peripheral arterial disease. Remember, we've got arteries and veins and capillaries surrounding each. In the inner lumen is the endothelium, and then we don't have smooth muscle and capillaries, but we have a different amount of smooth muscle between the arteries and the veins. The smooth muscle is what gives the artery and the vein elasticity, be able to dilate and constrict, and that dilation and constriction is all manifested on the smooth muscle, where the alpha-1 receptor constricts the vessel, making it narrower, reducing blood flow but increasing the pressure. The beta-2 receptor opens it up, vasodilates it, reducing the pressure inside but providing more flow through the blood vessel. Here is our arterial roadmap. Some of the bigger arteries you should definitely know. So subclavian artery, axillary, brachial, radial arteries would be important for you to know. Carotid and temporal arteries would be important for you to know. Obviously the thoracic and the dorsal aorta, the femoral arteries, the popliteal arteries, and the dorsalis pedis and posterior tibial arteries. Those would be examples of arteries that all clinicians should be able to locate, and in most of those be able to also palpate as well. So let's now talk about peripheral arterial disease. And the nice thing about talking about peripheral arterial disease, atherosclerosis, and peripheral arteries is we've already talked about atherosclerosis in coronary arteries. So a lot of this you already know. Remember that plaquing process builds up in the wall of the vessel, so it builds up subendothelium, below the endothelium. We know that that atherosclerotic plaque is very heterogeneous. There's a lot of different things going on in that plaque, and we know that that plaque can start to adversely impinge upon the smooth muscle, making that vessel less compliant or less elastic as you're losing those fibers that you need to vasodilate and vasoconstrict. What's all in that atherosclerotic plaque? There's a number of different lipids. There's esterified cholesterol, which we'll talk about in a minute here, low-density lipids, oxidized low-density lipids, macrophage foam cells, there's inflammatory mediators, calcification and fibrosis. Remember the vasa vasorum, the small capillaries that build in there that can lead to hemorrhage. And then hemorrhage within the plaque, and particularly when it disrupts the endothelium, will activate platelets, and now we can get thrombus on top of plaque, which can lead to complete occlusion of that blood vessel. So I want to talk in a little bit more detail about the fats in plaque and talk a little bit about hyperlipidemia as we move on here. So peripheral atherosclerotic disease can lead to loss of perfusion of an extremity. So in this case, someone with PAD can develop a cold, blue, cyanotic foot that has no perfusion, right? So what we want to be able to do is we want to pick up those people who are at risk of PAD, pick up symptoms and signs of PAD before they develop that ischemic extremity. So one of the symptoms of PAD is referred to as claudication. So what is claudication and where is it most likely felt? You can answer that, right? Pain in the calf muscles or pain in the leg muscles with exertion. Again, kind of think of claudication like angina. If your heart suddenly needs increased oxygen and that metabolic demand can't be met due to atherosclerotic disease in the coronary arteries, individual experiences angina. Claudication, I think of that as kind of being somewhat similar, right? Muscles are requiring increased blood flow and oxygenation during exertion, can't be supplied due to peripheral arterial disease, so the individual then starts feeling pain. We call that pain claudication. Pain with passive range of motion, paresthesias, extremities feeling cool, extremities looking pale, delayed capillary refill. These are all signs, potential signs of peripheral arterial disease. And then by the time the extremity becomes pulseless and cyanotic, that might be too late. So we want to be able to pick up an individual who's showing us signs of poor arterial flow into the extremities long before they completely clot that blood flow off and have no perfusion. So atherosclerotic disease can lead to this. Inflammation in blood vessels or vasculitis. A lot of different things can cause blood vessels to inflame, autoimmune things, different drugs and toxins can do this. Pharmacologic-induced vasoconstriction, remember we talked about this in terms of MI. If you take a very potent vasoconstrictor, you can get myocardial ischemia. Same thing, potent drug vasoconstrictors through the effect on alpha-1 can lead to vasoischemia of the extremities and other organs as well. And traumatic injury, for those of you that work in surgery and emergency medicine, you know that displaced fractures and burns and crush injuries can have devastating effect on peripheral blood vessels, leading to vascular insufficiency in that extremity. So there are a lot of different reasons why you can see vascular insufficiency in the extremity. The one that we're mostly focusing on in terms of this presentation is peripheral atherosclerotic disease. A nice way that you can pick up vascular insufficiency in an extremity from any reason is to do the exam called the ankle brachial index, right? This is extremely important when you are assessing an individual's peripheral blood flow. The ankle brachial index is comparing the systolic blood pressure at the brachial artery over the systolic blood pressure in an artery in the foot. In this case, you can look at the dorsalis pedis or the posterior tibial artery. Now you can palpate and you can palpate the arteries, right? Oh, the strong pulses up in the brachial and very weak pulses down in the lower extremity. That's one way of doing it. But the ABI puts a quantitative number on it where you take the systolic blood pressure of the you take the systolic blood pressure of the ankle over the systolic blood pressure of the brachial, ABI, excuse me on that, ABI, ankle over brachial. And then you can see the ABI value and how you can interpret that ABI value in terms of whether or not the person has or is at risk of peripheral vascular disease. Once you start seeing an ABI less than 0.5, that's problematic. Between 0.5 to 0.8, then that should start telling you something's happening here and that needs to be worked up because there probably is some degree of vascular insufficiency, right? So ideally, we want our ABI ratio to be as close to 1 as we can. We start seeing a risk of vascular insufficiency at ratios less than 0.8, and it's really problematic when the ratio is less than 0.5, all right? So ABI, ankle over brachial index. And here's just some pictures showing you that, you can palpate peripheral pulses, and if you're having a hard time finding a peripheral pulse by palpation, then pull out that handheld Doppler and try to listen for blood flow through the vessel that you're interested in. Look at that fracture, that elbow fracture. Look at that markedly displaced fracture of the humerus. That brachial artery runs right in front of that fracture. So a fracture like that, you can see how extremity fractures can lead to a vascular insufficiency. So again, be able to use these Dopplers and be able to pick out, find those arteries, and then quantitatively use that ABI in determining whether or not vascular insufficiency is present. Who has peripheral atherosclerotic disease? You can see that the incidence goes up the older you get. Even individuals in their 40s, there can be a small number of people in their 40s who can have this, but you can see the higher away you get from 60, the older you get from 60, the greater is going to be the risk. Overall, now I've seen this males greater than females, and I've seen males equal to females. African American tends to have a higher risk than Caucasian. In Hispanic, the female risk may be higher than the male risk. Family history, smoking, hypertension, diabetes, hyperlipidemia. It's kind of like the same risk factors for coronary artery disease, right? Look at atherosclerotic disease in the periphery versus atherosclerotic disease in the coronary arteries, and those risk factors are going to be the same, right? When should you consider this in your patients? If they're definitely over 70, if they're between 50 and 70 and they've got a smoking history or they're diabetic, anyone over 40 who's diabetic, if they're already talking about symptoms of claudication, so individuals who have claudication, people with ABIs less than 0.8, and if you know that they've got atherosclerotic disease at another site, right, they've already been diagnosed as having coronary artery disease or whatever, you know that they're also at risk of peripheral atherosclerotic disease as well. And then non-invasive Doppler ultrasound and invasive arteriography can be used by the imaging specialists, by the vascular surgeons to determine what degree of atherosclerotic disease there is, where is it, and how severe is the constriction. I know that you've probably seen a lot of these exams done in your respective institutions. The Doppler ultrasound, non-invasive, the injection of dye through the angiogram or arteriography. You can also do venography, right? You can look through you can inject arteries and look at arterial flow, and you can inject veins and look at venous flow. That then would be considered invasive due to the penetration into the vasculature. This slide here, I'm not going to read through you, but it just says that like coronary artery disease, where it can get worse, peripheral atherosclerotic disease can get worse as well. So you want to be able to pick it up, and you want to start intervening on this before the individual has limb ischemia, right, and complete vascular insufficiency. You know, a good example of progression of this and how bad it can get would be the diabetic foot ulcer, right? So you know that in diabetes, there's a high risk of vascular insufficiency due to the acceleration of the atherosclerotic plaquing, and that atherosclerotic plaquing can lead to intense vasoischemia of tissue, leading to the breakdown of tissue and ulcers, particularly on the feet, which can then get colonized with bacteria, lead to secondary infections, lead to gangrene, fasciitis, eventual amputation, right? So important to recognize atherosclerotic disease and do everything that can be done in terms of minimizing their risk and trying to decrease the progression of atherosclerotic disease. Okay, getting closer and closer to wrapping this up, what we want to talk about now are fats and hyperlipidemia. So have you guys seen any of this stuff? Have you seen in the upper right lipemic serum? See the normal serum on the left and the really fatty serum on the right. It almost looks like custard. There's so much fat in there. You've seen lipomas around the body, particularly in the subcutaneous tissue. Have you ever seen the cholesterol ring around the iris? Look at that picture of the eye, and you can see that ring, that kind of like milky ring around the iris. You might see that in an individual with really bad hyperlipidemia. And then the middle picture there showing you dissection of atherosclerotic plaque out of a peripheral blood vessel. So let's talk about the contributions of fats and lipids to vascular disease. Well, first let's have a little bit fun here and let's talk about Dr. Stremski's official food pyramid. So this is what my food pyramid looks like. It's got a strong foundation of red meat, bacon cheeseburgers, brats, and steak. Then we move into our third rung, which is the cheese rung. Any type of black cheese is good. Maybe not Limburger, I don't like that, but any type of black cheese is good. Macaroni and cheese, particularly with the crusty stuff sprinkled on top of it and baked into it. Oh man, that's awesome. Of course, deep fried cheese curds. Then we move into the potato group, of which there's only two legitimate potatoes, either French fries or potato chips. Extra bonus if you dip those chips in a fatty sauce, dip, if you will. And then it's all topped off with chocolate shake or chocolate malt. So this is my official food pyramid, and this may be why my internist put me on atorvastatin last year. Seriously, I've been on atorvastatin for a year, and I've had to change my diet because this just doesn't work really well in the long run, does it? All right, the idea of this is to talk about the role of diet in atherosclerotic disease, right? You know that diet plays a huge role in atherosclerotic disease. So here's our atherosclerotic plaque again. Remember, this plaque is occurring subendothelial. So now let's talk about the role of lipids in coronary artery disease and peripheral arterial disease. Fat cannot exist in water, right? Fat and water, oil and water don't mix. Fat is hydrophobic. Plasma is hydrophilic. So how do we get fat into plasma or into blood? We get fat into blood by incorporating it into protein, and these fat protein molecules are referred to as lipoproteins. Chylomicrons, very low density lipids, intermediate density lipids, low density lipids, and high density lipids are combinations of they're molecules, kind of like spheres, and they're combinations of different lipids conjugated with different fats. And you can see that they all vary in their density, they vary in their size and their diameter, and they vary by lipid and protein content. And to make this even more difficult and problematic, you can see the major types of different proteins that are found on these molecules. So the big molecule is called a lipoprotein, and the individual proteins within the lipoprotein are referred to as apolipoproteins. And you can see that they're in classes A, B, C, D, and E. So you have different types of apolipoproteins on these big molecules. When you look at this, you already know something about some of these. You know that the LDLs are problematic for atherosclerosis, and the HDLs may be protective against atherosclerosis. So we're going to concentrate on LDLs and HDLs, but we'll say a little bit about some of these other lipoproteins as well. Okay, a quick review of some fats. Upper left, you see cholesterol. Upper right, you see two fatty acids, saturated and unsaturated. Where saturated, all the carbon bonds are full of hydrogen. And then you can bind a fatty acid to cholesterol, forming what's called a cholesterol ester. So look at that picture in the blue box. You can see the structure of cholesterol on the right, and then you can see that fatty acid designated by that R group on the left. When you put a fatty acid onto cholesterol, you have a cholesterol ester. So on those lipoproteins, you may have free cholesterol, free fatty acids, or you may have the combination cholesterol ester where the fatty acid has been bound to cholesterol. Here is the fatty acid being combined to glycerol, and that is a triglyceride. So that's another fat that we find in lipoproteins is triglyceride. And you notice in a triglyceride there's fatty acids but no cholesterol. Individuals with lipid disorders can have disorders of cholesterol. They can have disorders of triglycerides, and they're different, and therefore management in terms of drugs may be different. Okay, so let's start with fat digestion. You eat a big fatty meal, right? You follow a meal such as what's shown in Stremski's food pyramid. You eat a big fatty meal in the GI tract. Those fat globules are going to be emulsified and broken down by bile salts, by phospholipids, by enzymes. And that fatty globule is all going to be broken down into small fats which can be absorbed by the gut. They'll be broken down into fatty acids, into glycerol, into cholesterol, and then those small fats are going to be absorbed out of the GI tract by the intestinal cell, and then the intestinal cell is going to repackage it all back up together. It's going to take those breakdown products of fatty digestion and reassemble it into our first lipoprotein called a chylomicron. And then those chylomicrons are going to be delivered via the lymphatic system to the liver. Okay, so fat starts with the diet. Eat a fatty meal, break it down into the smaller fats, cholesterol, fatty acids, triglycerides, absorb it, and then the intestinal cells reassemble it into chylomicrons, and then those chylomicrons are sent to the liver. And then in the liver, those chylomicrons are going to be reassembled into the other lipoproteins. And those other lipoproteins are the ones that we see in the traditional lipid panels, such as the LDLs and the HDLs. So it's kind of weird, right? You eat fat, you break down the fat into small molecules, you absorb it, you reassemble it into a chylomicron, you get that to the liver, and then those chylomicrons are broken down and then reassembled into the other lipoproteins. Remember, a lipoprotein is this complex molecule which is made up of varying types of fat and proteins. And when you get a traditional lipid panel, you're looking at concentrations of your triglycerides, your cholesterol, your HDLs, your LDLs, and your VLDLs. And a good serum profile is done following a 12-hour fast. And the reason for that is if you fast for 12 hours, you're going to have very low levels of chylomicrons. You don't want all those chylomicrons. You don't want to have chylomicrons in plasma because that's going to elevate your total triglyceride and elevate your total cholesterol levels. So best lipid panels are done after a 12-hour fast to minimize the amount of chylomicrons that are in there. We typically don't get chylomicrons in a traditional panel, right? We get total cholesterol, total triglyceride, HDL, LDL, and VLDL. This is like the basic traditional lipid panel. I have a discussion thread in Blackboard where you can talk about the worst lipid panel that you've ever seen and discuss that patient a little bit. Here's the general structure of a lipoprotein. You can see that a lipoprotein in general is spherical. Within the lipoprotein is free cholesterol, cholesterol esters, fatty acids, triglycerides, and proteins. You can see that the triglyceride and the cholesterol esters kind of make up the core. There's free triglyceride on there. There's phospholipids on the outer surface. And then as well on the outer surface, as you see a variety of different proteins. So in this case, you see protein B100, C, and E. And remember, they refer to those proteins as apolipoproteins. Those proteins can act as receptors, allows them to bind to cells, or those proteins can act as enzymes where they actually break down other molecules. Lipoproteins and apolipoproteins can be good or bad. When I say bad that they are contributing to atherosclerotic plaque. When I say good, they're doing some other function, some other necessary function in the human body other than contributing to a plaquing process. Okay, so I have a general feel of what a lipoprotein looks like and what are the different structures within the lipoprotein itself. And then remember, then we're going to categorize these things as being HDLs versus LDLs, etc. Lipoproteins, kind of what do? They carry triglyceride and fat. Density is kind of dependent on the triglyceride content. A higher density lipoprotein has a lower triglyceride content. Chylomicrons, again, are very large. They're not dense. They deliver fat from the gut to the lymphatic circulation to the liver. And then the ones that we see in our lipid panel, VLDL, LDL, and HDL, you can see what's going on with them. We want to look specifically at LDLs and HDLs. LDLs are transporting cholesterol around the body, and HDLs are scavenging cholesterol from the body. So you look at these 5 basic types of lipoproteins. Which ones do you want highest in your panel to reduce your cardiovascular risk, and which ones are the ones that actually induce cardiovascular risk? And the simple answer there is you want high HDLs and you want lower amount of LDLs, right? So we'll look at those two. Here's a low density lipid, an LDL. It's lost some triglyceride. It's very rich in cholesterol as a cholesterol ester. One of its primary proteins is a protein called B100, and this lipoprotein LDL is what is our primary risk for atherosclerotic disease. LDLs, certain types of LDLs are able to spontaneously diffuse into the subendothelium of blood vessels, meaning they can just get right underneath that endothelium. And when they get in there, when those LDLs get in there, they start setting up the deposition of fat and cholesterol into the subendothelium, into the vessel wall, and that begins the start of the plaquing of the atherosclerotic process. Some lipid panels now are not only looking at LDL numbers, but they're also looking at the apoprotein B serum levels. So you may see that depending on what type of lipid screens you're doing. You may see some of the actual proteins being assessed or quantitated in those lipid screens as well. Now, not all about LDLs are bad. In fact, LDLs are useful as cholesterol transporters because cholesterol is in fact a vital nutrient. Cholesterol is needed by certain cells to help build the cell membrane, and cholesterol is needed by other cells to actually synthesize steroid hormones. So cholesterol is the building block of steroid hormones like estrogens, testosterone, progesterone, vitamin D, cortisol, aldosterone. We have a lot of steroid molecules in our body which we synthesize, and we need cholesterol to do that. So our LDL lipoprotein can transport cholesterol around the body. When an LDL lipoprotein contacts a cell with an LDL receptor, that lipoprotein binds the cell through that apolipoprotein B. So look what's going on in the graphic here. There's the LDL floating around. There's a cell, and that cell wants the contents of the LDL. It wants that fat, and it wants that cholesterol. So the LDL will bind to the LDL receptor, get incorporated into the cell, and then enzymes within the cell are going to bust apart, degrade down that lipoprotein, and release the contents of the cholesterol, the triglycerides, etc., and then use those broken down components, the broken down fat components, and the broken down amino acid components in the varying intracellular processes which are needed. So we can't give cholesterol too bad of a rap, because without cholesterol, there's a lot of things we wouldn't be able to do. Integrity of the cell membrane, make steroid hormones. So this is the good way that LDLs interact with our cells, by actually binding the cell receptor and getting into the cell. We need that. Here's the problem with the LDL is when the LDL is able to the LDL doesn't bind a receptor, but it just gets through the endothelium of blood vessels, and then inside the endothelium, it starts laying down fat in the vessel wall. So in this case, the vessel lumen is at top, kind of shown in the kind of darker pink. You can see circulating LDLs. Those LDLs, see how they diffuse through the endothelial layer, and then once they get in the subendothelial space, they're going to start to be acted upon by phagocytic cells, particularly monocytes. Those phagocytic cells are going to gobble up the LDL, and as they gobble up the LDL, fats within the LDL are going to get oxidized. And remember, we talked about those foam cells. The foam cells are cells that you see in plaque, which are phagocytes, monocyte macrophage, which are loaded with fat. They're gobbling up that subendothelial fat. And inside those foam cells, that fat starts becoming generated into inflammatory mediators. Some of the literature will refer to these LDLs that diffuse into the subendothelial space as SDLDLs, so small, dense, low-density lipoproteins. You'll see that in the literature as well, SDLDLs. Think of those as the LDLs that are getting below the endothelium, into the wall, and then that fat's incorporated by macrophage forming the foam cells, and then within the foam cells, that fat is getting oxidized, and the oxidized breakdown products of fat result in the inflammatory process. So there's some histology of foam cells in plaque. See how those cells look got that kind of like white fatty vacuoles in there? Remember we talked about foam cells kind of looking like Mr. Bubble in that last presentation? So those macrophages suck up the LDLs. They're now called foam cells. And then within the foam cells, that lipid starts to get oxidized. And oxidizing those lipids will generate different biochemical molecules, and those biochemical molecules now initiate inflammatory responses in the blood vessels. That top structure there called the isoprostane, those isoproteins are, and similar molecules like it, are breakdown products of fat, so they're oxidized fat, and those isoproteins can act as inflammatory mediators. So there are some drugs and vitamin supplements that one can take which have been shown to be beneficial in inhibiting lipid oxidation. So vitamin C, vitamin E, folate, arginine, omega-3 fish oils, these have all shown some benefit in inhibiting that lipid oxidation. That lipid oxidation plays a role in the plaquing process because lipid oxidation is generating these inflammatory mediators like the isoproteins, which is further contributing to the plaquing process and vessel damage. The HDLs now are protective. These are smaller, they have high density, they're synthesized in the liver. Notice that they have different proteins on them. They have A, C, and E protein. They have a very low triglyceride content. They have a low lipid percent, and they scavenge cholesterol away from vascular tissue. HDLs also have an enzyme, look kind of at the lower portion there, paranoxinase, and that enzyme helps inhibit oxidation of lipids. Remember, we don't want lipids to oxidize because oxidized lipids contribute to the plaquing process, so there's another way that the HDLs are protective against that plaquing process. And the other thing about HDLs that have been found about HDLs is they can release, or they're involved in the synthesis of nitric oxide. Remember, nitric oxide is a vasodilator. That's good when you want to get blood flow through a blood vessel. And these HDLs can also activate beta islet cells in the pancreas and help us release insulin. So a lot of good properties to the HDLs, which make them vascular and cardioprotective. Okay, so now let's get clinical. Let's look at the traditional lipid panel. So let's look at this individual's lipid panel. They're looking at total cholesterol, the cholesterol from all the sources. They're looking at total triglyceride from all the sources. Then they're quantitating the HDL cholesterol, the LDL cholesterol, the VLDL, and then they're giving you a ratio of cholesterol to HDL, all right? So again, we want our HDLs high, and we want our cholesterol to HDL ratio low. So those are the big things that we're looking for in this lipid panel, right? We want cholesterol to the higher the ratio of cholesterol to HDL, the greater is the cardiovascular risk. So our best ratio would be 3.5 or lower. A desirable ratio would be 5 or lower, okay? So look at this individual. You see his total cholesterol is 158. Then you see his HDL cholesterol is 43, and then you get 158 over 43, and then you can come up with that cholesterol to HDL ratio, right? So this is important, to be able to look at a lipid panel and pick that out and be able to interpret a lipid panel in terms of what's high and low. And again, remember, I'll always give you the normal numbers. Don't memorize numbers, just be able to look at the number in the panel to the range and then be able to make some interpretation in terms of whether or not this is an abnormal lipid panel and whether or not your patient would have a higher risk of cardiovascular disease based on the results of the lipid panel, right? You guys be able to do that. Okay, lipid pathology. So if somebody has too much pathologic amount of lipid, we call that a hyperlipoproteinemia, an HLP. HLP is a variety of different metabolic disorders that leads to increased concentrations of lipids and lipoproteins. And the increased amount of lipid and lipoprotein can lead to increased risk of cardiovascular disease. There's a couple rules about HLPs. Number one, you don't have to be obese to have an HLP. There are numbers of individuals who have normal body mass indices but still have an HLP, still have some disorder of fat metabolism. And HLPs can be broken down into two primary types. Like I said earlier in the talk, you can either have a problem with too much cholesterol or you can have a problem with too much triglyceride. And then we can classify these HLPs by something called Fredrickson's classification scheme. So here are 6 different types of HLPs. And when you look at it, you can see that each HLP involves a different type of lipoprotein. Now, don't get too worried here. The only one that I'm going to talk about and the only one that I'm going to have you responsible for in terms of testing will be the type 2A. It's called familial hypercholesterolemia. And I would imagine that most individuals in this course have seen a patient with type 2A familial hypercholesterolemia. Here's a really simple question. What do you think is this person's problem with type 2A? Is it too much cholesterol or too much triglyceride? Right, too much cholesterol. Now look at this and look at type 4. What's their problem? Too much cholesterol or too much triglyceride? Right, type 4, too much triglyceride. Right, so remember, cholesterol and triglycerides are very distinctly different types of fat molecules, right? All right, so let's just talk a little bit about type 2A, the individual who has markedly elevated LDLs. Remember, the LDLs are high in cholesterol ester, so if their LDL levels are up, their cholesterol levels are going to be sky high as well, okay? Here's type 2 familial hypercholesterolemia, type 2A. And it's a genetic disorder, and the problem is they have a genetic mutation that leads to lack of the LDL receptor. Remember, the LDL receptor is how the low-density lipoprotein binds to a cell. And when it binds into a cell, it can be incorporated into the cell, and then we can use the fat and the proteins of that LDL and positive metabolic processes within the cell, such as cholesterol synthesis or cell membrane synthesis, right? If you don't have that LDL receptor, then the LDLs they don't have anything to attach to, and they're just going to accumulate, build up in serum, elevating the LDL levels in serum, elevating the cholesterol levels in serum, and increasing the amount of LDL, which is going to be available to get subendothelial and get into the plaque, right? So this is an autosomal dominant disorder. About 1 in 500 are heterozygous, about 1 in a million are homozygous. The ones that are homozygous, which are carrying 2 alleles, 2 mutant alleles, those are the ones that are going to be most severely affected, and those are the people that you hear about who have stroke and MI due to elevated cholesterol levels in their 20s and 30s. They typically have homozygous type 2A familial hypercholesterolemia. There's a number of different mutations that are known for that LDL receptor. So You can have type 2A, you can have a bunch of different people with type 2A, and depending on their mutation, they may have different clinical severity of that type 2A, right? So their phenotype, how they're affected, may be different based on the mutation. Something that we know about individuals with type 2A is they can develop these xanthomas, which are essentially this precipitation of cholesterol in subcutaneous tissue. These are individuals who can also develop that ring of cholesterol in the iris, right? Remember I showed that a couple slides ago. The high LDL and the high total cholesterol level in these individuals place them at risk of early myocardial infarction and stroke. So these individuals need to be fairly aggressively treated with lifestyle and dietary changes. And the most important drug that these individuals go on is a statin drug. And I'll show you what a statin drug here is in a minute. Statin is one type of lipid-lowering drug. It's beneficial for lowering cholesterol. But we have other types of lipid-lowering drugs as well that play different roles in terms of what type of fat it lowers, what type of lipoprotein it's active on. So know a little bit about type 2A. I want you to understand the role of that LDL receptor and how mutations of that receptor can lead to inefficiency of the receptor. Therefore, you can't get that low density lipid into cells. It accumulates in plasma, raises the LDL and cholesterol content of plasma, and then that excessive amount can contribute to the plaquing process. The most important lipid-lowering drug is a drug class called the statin. There is a chemical structure of what that statin looks like, and what the statin does is it blocks cholesterol synthesis. So we have cholesterol in our body due to either dietary cholesterol or due to our own endogenous synthesis of cholesterol. We make more cholesterol than we eat, right? So it's important in an individual suffering from type 2A or any other disorder of elevated cholesterol to be able to inhibit endogenous synthesis, and that's where the statins work. The statins work on an enzyme called HMG-CoA. So very early in the synthesis of cholesterol, it blocks it. Therefore, you don't make cholesterol. By not making cholesterol, your cholesterol levels can lower. In terms of the clinical world, starting an individual on a statin, we have three choices. We can start them on a high intensity, a moderate intensity, or a low intensity. And you can see that there's a number of different statins on the market, and depending on what statin you're using and what dose you're giving the patient, you get a greater effect or a less effect out of it. So atorvastatin, rosuvastatin at the higher dose are considered to be high intensity statins. Well, how do you determine? How do you determine if somebody needs a statin? And then if they need a statin, how do you determine it? Should it be high, moderate, or low intensity? That's all based on what's called the ASCVD risk. And the ASCVD risk is a risk factor calculator that you place in all the patient's risk factors, and then it gives you their risk of having a serious cardiovascular event in the next 10 years. It's not 100% predictive by any means. It doesn't work well if you're over the age of 79. And it works best if your LDL cholesterol levels are between 70 and 89. So there is the risk calculator. I would imagine that a lot of you may have access to this risk calculator online within your electronic medical record. You may have the app that you carry on your phone. But look that up and then play with that for a little bit and put in the risk factors and then come up with what type of ASCV 10-year risk you're known or fictitious individual gets. I used my own parameters and put that in. I used my own parameters and put that in there. I think my risk came out to be somewhere between 3 and 4%. So that's why my internist put me on a moderate intensity statin. He didn't put me on a high intensity statin. If my risk factors would have come up higher and closer to 10%, then he probably would have said I should go on a high intensity statin. I won't make you memorize that table, but I do want you, for learning, please go to that website, cue that in and then play with that, and then play around with the variables and see how ASCVD risk changes based on how you vary the risk factors. And then this is how how you decide in terms of how you use a statin. So, does the individual already have a cardiac event? Did they already have a stroke? Did they already have a heart attack? Are they already being treated for coronary artery disease or peripheral vascular disease, right? If they are, and they're under the age of 75 and they don't have any contraindications given a statin, they go on high intensity statin. If they're over the age of 75, then they put them on a moderate intensity. More adverse effects are seen in elderly on statins versus younger individuals. 75 looks like it's the cutoff here. Okay? So if you've already had a cardiac event, if you've already had a cardiovascular event, then you should be on a high intensity statin. If you're under the age of 75, moderate intensity if you're over the age of 75. If you have not had a cardiovascular event and your low density cholesterol is greater than 190, you go on a high intensity statin. If you have not had an event and you have diabetes, right, then they look at the 10-year risk. If your 10-year risk is less than 7.5%, you go on a moderate. If your 10-year risk is greater than 7.5%, then you go on a high intensity. Right, so it's all based on, did you have an event, your age, your LDL-C, and your ASCVD risk factor, right? If your ASCVD risk factor is greater than 7.5%, meaning you got a better than 7.5% chance of having a cardiovascular event in the next 10 years, they're going to put you on a high intensity statin. I'm not going to test you on anything regarding the statins. I just thought that since we were talking about lipids, this would be a good time to just really quickly introduce what the statin drug class is and how the dosing works in terms of high and moderate intensity. And I'm sure that you'll get much more of this in detail, probably even better explained than I just did it really quickly here in a pharmacology class. Okay? Statins are one of a number of different drugs that can be used to treat people who have either coronary or peripheral atherosclerosis. So if you look at this slide here, you can see the drug class on the left. You can see what that drug class does in the middle, and then you can see some representative drugs within the class. So Lipitor is a statin drug which treats hyperlipidemia and stabilizes plaque, lowering risk of a cardiovascular event. Loveza in fish oils are omega-3 fatty acids that block lipid oxidation, right? Enalapril, lisinopril, ACE inhibitors, valsartan, losartan, ARB drugs, angiotensin receptor blocking drugs, all for managing hypertension, right? So this is kind of an important slide. It just at least shows you all the variety of different drugs that you can use to treat an individual with atherosclerotic disease. And again, you can see the variation of the different mechanisms of action. And then finally, in terms of drug therapy, this is really, really cool. The use of monoclonal antibodies in cardiology. Remember, we introduced monoclonal antibodies for autoimmune diseases like RA and psoriasis, and we'll talk a little bit more about this in the GI unit and the neuro unit when we talk about some autoimmune diseases. Here is using monoclonal antibodies in the world of cardiology, and none of this is really autoimmune. This is all trying to target different proteins that are known to play a role in atherosclerotic diseases. And some of you may have seen this, particularly if you're working in a cardiology if you're in a cardiology type career, you've seen these drugs come out within the last couple of years. Evolocumab Repatha is a drug that's used to treat people with markedly elevated LDL levels. The protein that this monoclonal antibody binds is called PCSK9 enzyme, and that enzyme breaks down the LDL receptor. When you break down the LDL receptor, you can't incorporate your LDLs up into the cell, so therefore they accumulate in plasma and they accumulate in the subendothelium. So in an individual with really high LDL cholesterol that's not responding to high intensity statin, here's a new monoclonal antibody to treat that. Abciximab is a monoclonal antibody that inhibits platelets. And if you remember the platelet plug, there's a receptor called GP2B3A, which helps platelets cross-bind each other, increases the platelet activation. In a cath lab, when someone's going through angioplasty, they may get this monoclonal antibody to decrease platelet activation and make the angioplasty and the catheterization more successful. And now, this is really, really cool. We talked about the role of inflammation in atherosclerotic plaque. Now there's two monoclonal antibodies, canakinumab and tocilizumab, which are targeting two different inflammatory mediators known to play a role in cardiovascular plaque, where canakinumab is targeting interleukin B1 and tocilizumab is targeting interleukin 6. Both of these may be beneficial in managing the inflammatory component of coronary artery disease, where the ILARIS clinical trials are looking at that in terms of prophylaxis, and Actemra clinical trials looking at it in terms of post-MI inflammation. So I just think that's really cool and amazing to see how monoclonal antibodies are now finding a niche role in the world of cardiology. I actually posted a FYI for your information only article on Blackboard if you want to look a little deeper at monoclonals in cardiology. All right, last topic, folks. This is a little bit on pediatric cardiology. We got about 10 quick slides to go through here. This is just going to, again, be a very quick overview of congenital heart disease. When I say congenital heart disease, I'm talking about anatomic malformations within the heart and the great vessels that can lead an infant or a child to develop impaired circulation and heart failure. Take a look at see the question mark there? Look at that heart. What's wrong with that heart? Can you see it? Look at the right side of the heart and then the left side of the heart. See the aorta coming off the right side and the pulmonary artery coming off the left side? That's an example of congenital heart disease. That's an example of a malformation, and this is called transposition of the great vessels. Imagine that, the aorta coming off the left and the pulmonary artery coming out of the right. So we're just going to look really quickly at some of these disorders and talk about the presentation of infants in heart failure. And this will be quick. In utero, the developing infant does not use lungs, right? All oxygenation is occurring through the placenta. So deoxygenated blood is leaving the infant through 2 umbilical arteries going to the placenta, picking up oxygen, and then that oxygenated blood is returning back to the infant via the umbilical vein. The umbilical vein is oxygenated, and that umbilical vein is eventually going to meet up with the inferior vena cava and empty that oxygenated blood into the right heart. Now, we don't need to get a whole lot of blood to the lungs because the lungs aren't oxygenating, so we're going to shift or push that oxygenated blood over to the left side, and we can do that 2 ways. Through a hole between the atrium called the foramen ovale, or through a communication between the pulmonary artery and the aorta called the ductus arteriosus. Both of those open in the in utero fetus allows oxygenated blood to move from the right heart into the left heart, and then the left heart can move that oxygenated blood through the rest of the body. Again, you're shunting blood right to left because the lungs are essentially non-functional in utero, right? That infant is living in amniotic fluid. There's no oxygenation being done by the lungs. It's all being done by the placenta. Okay, following birth, fetal in utero circulation needs to change over to infant circulation. So we weren't using the lungs in utero. Now we got to start using the lungs outside of mom, right? So baby exits, comes out into the cold, takes a deep breath and screams. Now baby's going to fill the lungs up with oxygen. The oxygenation within the lungs is going to dilate the pulmonary arteries, and the dilation of the pulmonary arteries is going to result in decreased pressure on the right side of the heart, Then the cord is clamped, and when the cord is clamped, that will increase pressure on the left side of the heart. So remember, in utero, you had this right to left shunting, blood trying to bypass the lungs. It can go from the right atrium to the left atrium through the foramen ovale, and from the pulmonary artery to the aorta via the ductus arteriosus. Now, following birth, right-sided pressures drop. Over time, the foramen ovale and the ductus arteriosus will start to close, and then we've stopped that right to left-sided shunting, and now we're back to what's considered to be normal circulation, where deoxygenated blood is coming to the right heart, going right atrium, right ventricle, pulmonary arteries, lungs, and then oxygenated blood comes back left atrium, left ventricle, out the aorta into systemic circulation. So it's pretty amazing how that happens, how the in utero shunt keeps the infant alive in an aerobic environment, but then very quickly after being delivered, changes in right and left-sided pressure and closing of the foramen ovale and the ductus arteriosus sets that individual up, sets that newborn infant up for what's normal extrauterine circulation. So now, congenital heart disease. Congenital heart disease is malformation of the anatomy of either the heart or the great vessels. And the great vessels, again, are referring to the vena cava, the pulmonary veins, pulmonary arteries, and the aorta, right? Just like any disease, congenital heart disease can be on a severity scale. Some infants can have certain congenital heart defects that have minimal to zero dysfunction. Some infants have defects which are incompatible with life. And then there's a whole variety of different types of impairments in the middle, which can be medically, procedurally, and surgically treated to optimize blood flow in and through the heart. Congenital disease is the most common type of congenital malformation in the USA and worldwide. Congenital heart disease is not just one specific lesions, but there are numbers of different types of lesions involving the heart and the great vessels that make up CHD. Some individuals with CHD may have one malformation. Some individuals with CHD may have multiple malformations. Why does CHD occur? We know it's got a higher prevalence in certain individuals with genetic disorders such as trisomy 21. We know that maternal exposure to certain types of infections during pregnancy can increase the incidence of congenital heart disease in the newborn. Same as exposure to certain types of teratogenic drugs during pregnancy, radiation exposure during pregnancy. We know that maternal diabetes mellitus increases the risk of CHD in the offspring, and we know that increasing maternal age can also increase risk, particularly age greater than 35. All right, so congenital heart disease, a lot of different things can be going on here. Here's just a sample of the different types of lesions, the different types of anatomic malformations that one can see in congenital heart disease. Look on the right, on left column, come down halfway and you see a disorder called dextrocardia. And dextrocardia, all that is the heart is just flipped in a mirror image. Everything is there, everything is where it's supposed to be. It's connected right, there's no holes, there's no obstructions, and everything works. The heart is just connected. The heart is not connected. The heart is just inverted in a mirror image, so it looks more right-sided, dextro, right-sided versus left-sided, levo, left-sided, right? And that may have zero impact whatsoever on the cardiac physiology, all right? Now, sometimes dextrocardia is associated with other types of congenital abnormalities, but if the only thing the infant has is dextrocardia, that may not require any interventions whatsoever, versus some of the other things that are on here which may require staged surgical repairs, medications for heart failure. So we're just going to look at a few of these just to get you, if you've never seen congenital heart disease, we're just going to look at a few of these to get you to understand some of the various forms of congenital heart disease. First off, how do you know if an infant has congenital heart disease? About 1 in 500 infants born in the USA have some form of it. So more and more, we know that more detailed echocardiograms, ultrasounds are being done during pregnancy. A more detailed ultrasound of the fetal heart is a fetal echocardiogram. That can be done during pregnancy, and that can be very good at picking up specific types of CHD before that infant is delivered. That way we know, hey, we've got an infant here who's going to be delivered who's got this known form of CHD. Probably best to deliver this infant in a tertiary care center where we've got pediatric neonatology and cardiology ready to deal with this infant as soon as they come out, as opposed to being surprised, right? Once infants are born, we can look for signs of cardiac and respiratory distress in terms of how they're feeding, difficulty breathing, cardiac murmurs, aberrancies that may feel in pulses and blood pressures. One of the ways to screen for congenital heart disease in newborn infants now is to put them on a pulse oximeter after birth. Some of these congenital heart diseases result in hypoxemia or drop in oxygenation of blood, and that is very easily picked up with a non-invasive pulse oximeter. So infants, newborn infants who are born, that's redundant. Newborn infants, right, now in the neonatal unit can have pulse oximetry put on for a period of time, checked in the different extremities, and if there's discrepancies in the pulse oximetry, that may mean that that child now may have a form of congenital heart disease that needs to be further worked up by echocardiogram or cardiac catheterization. And final diagnosis in terms of what is the heart lesion and how it's affecting that infant will be done through echocardiogram and cardiac catheterization done after that child's been born. So couple things. If you've never worked in pediatric cardiology, I would suggest to take a look at the Children's Hospital of Wisconsin Herma Heart Center website. Won't test you on anything on that website, but just kind of spin around it and look around it and look at all the different types of lesions, look at the multidisciplinary approach that is done in that clinic. You may have a special interest in looking to see how mid-level providers such as nurse practitioners operate within the Herma Heart Center and within specific patients, some working transplant, some working cath lab, some working neonatal ICU, etc. And then I've got a question that you can answer in one of the discussion threads. If you have worked in a newborn nursery and you have used pulse oximetry to screen newborn infants for CHD, why don't you pick that one up as a thread and tell us a little bit about how that's done and whether or not you may have actually found an unsuspected newborn infant of actually having some form of CHD. So a non-invasive but very important test now done in newborn nurseries to look for, give a clue that there might be some type of heart or vessel malformation. And then really quickly, let's just look at a couple of them. This is called a ventricular septal defects. Remember, in the normal heart, there's this big muscular septum separating right from left. A VSD, ventricular septal defect, is a hole that allows the right and the left ventricles to communicate with each other. You can see the diagram at the top, and then you can actually see a heart with the big hole shown to you with that probe going through the hole in the septum. This one's fairly common in terms of infants with congenital heart disease. About 30% of infants with congenital heart disease have some type of ventricular septal defect. Some of those may be very small and membranous, some may be very large and muscular, and it's an opening between the right and the left ventricle. In utero, the blood is shunting from right to left, which is okay, because remember, in utero, the oxygenated blood is on the right side and you want to move it to the left. But after birth, once we go to normal neonatal extrauterine circulation and the pressure on the left side is higher, now blood starts to shunt from the left to the right. And that can be problematic because now rather than you're getting less blood going out of the aorta into systemic circulation, you're getting more blood going back into the right ventricle, overloading the right side of the heart, and that can lead to pulmonary hypertension and pulmonary edema. And the infant then gets symptomatic due to the pulmonary hypertension and the pulmonary edema. Interesting, sometimes these VSDs close spontaneously, and sometimes these VSDs actually have to be repaired with a patch and open heart surgery. Hypoplastic left heart is a state where the left side of the heart, particularly the left ventricle, is underdeveloped. And in utero, it's okay because due to opening of the ductus arteriosus and the communication between the pulmonary side and the aortic side, we can still get adequate oxygenated blood moving around the body. But now after the infant is born and as that ductus arteriosus closes off, that small malformed left ventricle is going to be unable to support systemic circulation. So these infants may look very well in utero and they may look very well after delivery for a number of hours and maybe even up to a day. But as the ductus arteriosus starts to close down and you don't get that shunting of blood, now the left ventricle can't support systemic circulation, and that infant goes into very rapidly into a state of circulatory decompensation. So this is present in about 1 in 10,000 live births, counts for about 8% of all cases of congenital heart disease. This one's pretty severe and without intervention will be fatal within 2 to 3 days. Within the last 10 years, a number of Well, within the last 10 years, a staged surgical repair of these infants has pretty much been close to perfected, such that infants born with hypoplastic left ventricle a while ago would not survive. There was nothing that could be done. Now with the staged surgical repair, essentially what they're doing is they're creating a process such that the right ventricle is able to supply the systemic circulation. It's really, really interesting how this is done. If you're in pediatric cardiology and working in a pediatric neonatal ICU or pediatric ICU, you've seen that staged repair. Staged repair, again, is something that's usually happening from immediate to a couple of weeks to a couple of years, right? It's child is coming back for one surgery, then the next, and the next at various times in the first year or two of life. Very, very impressive how that can be done. I remember a friend of mine back in the mid-1990s had her first infant born with a hypoplastic left heart, and there was nothing that could be done at that point, and that infant died within 2 days of being born. And I know that they then used that infant as an organ donor. I believe that they had both the lungs and kidneys and some other tissue was donated from that infant. But now, hypoplastic left ventricle with very intensive staged surgical repair, a lot of these children are going on to live very full and healthy lives. And again, this how old is the oldest child who has hypoplastic left ventricle? I'm not sure, but I'm quite positive there's got to be some kids now that are in their teenage years who have survived hypoplastic left heart. And eventually some of them may need a heart transplant, but they're surviving and they're doing extremely well. This is what's called a ductal dependent lesion. The infant is doing okay as long as the ductus arteriosus is open, but when that ductus arteriosus closes down, they go into a state of circulatory collapse. Here's another ductal dependent lesion. This is transposition of the great vessels. And you can see that the aorta and the pulmonary artery are essentially switched. And this is incompatible with extrauterine life. There needs to be some type of communication between the left and right to be able to get mixed blood, to be able to get some form of oxygenated blood moving through the heart. That can happen through a patent ductus arteriosus, or it can happen through a patent foramen ovale. As long as they're open, there's mixing of blood and you can get some oxygenation of tissue, but as soon as those structures close, then the infant very rapidly becomes hypoxemic and this becomes incompatible with life. So one of the first interventions in these infants is to open the ductus arteriosus or keep the foramen ovale open through a procedure done in the cardiac cath lab, where the foramen ovale is essentially blown open to keep communication between the right and the left side of the heart. And then there are a number of different surgical procedures which are done, which will switch the great vessels back to their proper ventricle. Obviously, that's a pretty hardcore lesion, right? And the infant has to go through a lot of stuff to be able to get to the point where that heart now is connected or wired properly, right? So ductal dependent lesions, there's a couple of them where the infant does fine in utero, but as soon as the ductus arteriosus starts to close off in extrauterine life, it leads to a state of hypoxemia and circulatory collapse. So there is a drug called PGE1, alprostadil. It's a prostaglandin, and when infused in an infant recognized as having circulatory failure and hypoxemia in the first hours or days of life, where that might be due to a heart lesion, one of the first things that can be done is to begin an infusion of prostaglandin E1 to keep that ductus arteriosus open long enough that the infant survives to be able to get to a cardiac cath, figure out what's wrong, and do that initial shunting procedure to maintain mixing of blood. And if you can maintain mixing of blood, you can maintain some oxygenation of tissue. Very, very dramatic when this is done. I've had the opportunity to be involved in a couple of these in my career where an infant seemed to be well initially, went home in 24 hours, and then comes in and marked hypoxemia and circulatory collapse, suspected of potentially having a ductal dependent lesion, prostaglandin infusion started, signs of life come back, better circulation, better tissue oxygenation, and then very quickly being taken into a cardiac cath lab for diagnosis and an initial cath procedure to further stabilize shunting of blood. If you've ever been involved in anything like this, and I think this is so absolutely cool, why don't you tell us about that in one of the discussion threads as well? Tell us about an infant resuscitation that you participated in where a prostaglandin E infusion was used. Whew, 2.5 hours. There we go. We have kind of ended cardiology now. We've talked about a lot of things, but we really hit some stuff fairly cursory. I think we spent most detail talking about atherosclerosis. I think you should have a good understanding of atherosclerosis. Let me say one last thing, infants and heart failure. So you know how adults present in heart failure. Let's talk about infants and their presentation of heart failure. Same thing, respiratory distress, altered mental status, poor peripheral circulation, impaired capillary refill time, hypotension, poor blood pressures. Pulmonary edema can lead to listening to the lungs, hearing diminished breath sounds, pulmonic rales, hepatomegaly. But one thing that you may not see in an infant in heart failure is peripheral edema. Again, peripheral edema, particularly lower extremity edema, usually due to gravitational pull of fluid. Infants aren't up and walking around. They're usually on their back, right? So you don't see peripheral edema very commonly in an infant in heart failure. If you see an infant with tachypnea, tachycardia, poor perfusion, you feel a distended liver, start thinking heart failure. Listen really close to lungs for pulmonic rales, and a quick chest x-ray can show you pulmonary edema and a cardiomegaly similar to what you see in an adult. So be aware of that. Sorry I didn't have a slide on that, but that was another important point I wanted to make. Okay, so that just extended us to 2 hours and 33 minutes, and I'm shutting up right now. We're done. Good luck on the quiz. Finish up the discussion boards, and then next week we'll get into renal. Thank you for hanging in there with me. Goodbye.